You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 22nd, 2018. This week, a few more comments on PREDIMED retraction, testing for coronary artery disease, alcohol, stroke care in the elderly, and genetic testing. So last week, I spent a fair amount of time on the PREDIMED retraction. The news this week pertains to comments made by Stanford professor John Ioannidis about the trial. Ioannidis is a prolific researcher in methodology and evidence, and he's influential and well-known because he often speaks candidly about the flaws in clinical science. Remember, Ioannidis wrote one of the most downloaded papers ever, Why Most Published Research Findings Are False, and this was in PLOS. I've read the paper numerous times. It's excellent. Now, here are a few comments that Ioannidis made about the PREDIMED retraction. He made these in a session with Dr. Eric Topol, in an interview with Dr. Topol. Ioannidis said that I think what we saw in the retraction was a signal that the data had major flaws, and that the problem that was detected by the statistical analysis is not explained by the correction that led to the republication. So his strong belief is that PREDIMED is a seriously flawed trial, and he said, I cannot trust it any longer. Ioannidis suggested that to instill trust, he called for an independent committee to analyze the raw data, not the clean data, but the raw data. Now, these comments sound pretty rough on the PREDIMED researchers, but then Ioannidis kind of backpedals a little and says this: I still hope that they will allow some further probing into this trial. And he says, I think it would be a lost opportunity if we don't learn more, because I think it's just the tip of the iceberg. There's far more that's going on, and I think that the PREDIMED investigators, the PREDIMED trial, may be the most honest in a way compared to other trials that may be less honest. Now, that last comment is something. PREDIMED, a trial that had obvious randomization irregularities, and one that went from an RCT to an observational study after a retraction, may be the most honest in a way. Now, I report on these Ioannidis comments because they make you think. Yes, I know some in the research field don't like his criticisms, but as an outside observer and a doctor who has to use this evidence in real patients, and one who has practiced long enough, I've practiced long enough to see plenty of evidence shenanigans, I'm drawn to Professor Ioannidis' call for better evidence. Second topic is ischemia-based testing, and I call this the cardiology train, the search for ischemia and then the treatment of stable ischemic heart disease. Treadmills, nuclear, stress echoes, then cath, then PCI. These are the moneymakers for cardiology, and I'm sorry to say this, but a bunch of it is wasteful, low-value, flat-of-the-curve spending. The question is, why do so many cardiology practices still do so much of this over-testing? Now, one answer could be malpractice concerns. Let's say a patient has a symptom or a sign, and it might look obvious in hindsight after the patient had a big heart attack, and the doctor did not order a stress test or cath. The concern is that that doctor could have been sued for missing a warning sign. Thus, one of the reasons for massive overuse of ischemia-driven testing is fear of litigation. So a nifty observational study from numerous authors set out to answer this question, and here's what they did. They took about 35,000 doctors from states that just had recently passed malpractice caps on awards, and 39,000 docs that didn't have malpractice award caps. So think about it. On an absolute terms, the chance that a state having a malpractice cap would have any effect on a single physician is extremely small. But what these malpractice caps do have an effect on is that they make doctors feel safer from liability. Remember the lessons from behavioral psychology. People feel risk. So the findings of this observational study are provocative. The doctors from both groups performed a similar number of ischemic evaluations. But those doctors from states that had malpractice caps conducted fewer initial caths they referred fewer stress-tested patients for cath, and they referred fewer patients for revascularizations. Now, these findings go a little bit against the prevailing notion, and one that I shared, that the fear of litigation, it gets played up a lot, but in reality plays little role in overuse. Now, these observations make you think that maybe malpractice concerns have to be considered more strongly. But it should be said, crucially, that this is an observational study, and always there could be other confounding reasons besides changes in malpractice caps that cause these differences. I still think that most overuse of ischemia-based testing comes from the bias of just doing what's always been done, plus the failure to read evidence and stay current, and of course, financial incentives push us towards doing more testing and more procedures. Third topic today is on alcohol. Now, there are a few certainties in medicine, but here is one of them. We will never know if moderate alcohol consumption is protective, neutral, or harmful to human health. And the main reason why there will always be uncertainty over alcohol is that we'll only have hopelessly confounded observational studies. And this week, an attempt to study alcohol in an RCT fell through when the NIH pulled funding of the MACH-15 trial. This RCT aimed to assess the effects of moderate alcohol usage or abstention on major adverse cardiac events over a 6-year period. The NIH pulled funding because of some issues with trial design. For instance, NIH was upset that the investigators did not include heart failure in the composite endpoint. The NIH also had concerns with partial funding from alcohol beverage industry. Now, this is kind of funny. What was their concern here? Bias? I mean, I can't imagine how funding from makers of alcohol would trigger concerns over bias in the trial. I mean, think about it. Drug and device makers surely exert no undue bias of clinical trials of their products. Why would the NIH think that makers of alcohol aren't interested in a fair and square test? I know, this is kind of funny, but seriously, as an AF doctor, I counsel people often on alcohol use. I don't preach, I don't tell them what to do, I just present the evidence as I understand it. I tell AF patients about the association studies, and I tell heart failure patients about the clear role that alcohol can have on worsening LV function. I also explain to those patients that ask me that the French paradox could also be explained by the fact that Europeans walk more, eat less junk food, and live in breathtakingly beautiful countries. Fourth topic today is stroke care in the elderly. Now, I want to discuss an abstract presented at a European stroke meeting, but first I want to tell you about a case that's burned into my memory. It was considered a big save. We had just seen this woman on the cardiology ward for new AF, and we perseverated over using an anticoagulation because of her advanced age. She was north of 90 years old. We decided to do it, to use anticoagulation because she had a decent, albeit limited, functional capacity. And literally, right after we entered the order for the anticoagulant, before she got the anticoagulant, the nurse called because she was not moving her right side. And the stroke team swooped in and took action. And despite her age, she underwent a mechanical thrombectomy. It was a hard case. I mean, what case isn't in 90-year-olds? She had tons of tortuosity, and it took a good long time to get the major vessel open. Now, this patient survived, and on paper, at 30 days was probably counted as a positive result, as she was progressing through stroke rehab. But then it started. It was repeat admissions for stuff that happens to old people who have major events like this. First, she had a urinary tract infection and admission, then an aspiration pneumonia. A few weeks later, hyponatremia and volume depletion, and it took over a year and multiple admissions, but she eventually died. The thrombectomy had lessened her stroke, no doubt, but probably also had prolonged her death. Now, with that in mind, I'll tell you about a study from a group from Portugal who performed a retrospective analysis on about 200 patients at their center who underwent mechanical thrombectomy. 134 of these patients were younger than 80 and 70 patients were older. Now, they were somewhat matched on baseline characteristics, and the primary endpoint was poor function at 3 months as measured by the modified Rankin score greater than 3. The bottom line results were that 67% of older patients had poor function at 3 months compared with only 46% of younger patients. And that's not surprising. But what got emphasized is that 32%, 1 in 3 patients who were older than age 80 ended up with independent function at 3 months. And so the PI of the single-center study, non-controlled, non-published study, said this in the news story, that the results of this study do support recommendations for thrombectomy to these very old patients who can benefit from it. He said further research is needed to identify factors that are associated with their favorable outcome. Now, friends, this is a huge problem with medical science. No, this study does not at all support these contentions. And further research is not needed to find out what factors are associated with favorable outcomes. Further research is needed to know if we are helping or harming older patients with this procedure. You can't tell from this sort of study. You have to randomize older patients to conventional therapy or intervention and then follow them for a period of time, a year. And when doing studies of the very old, it's crucial to look at whether the extension of life associated with the kind of outcomes my patient had or whether it was indeed a good quality of life. Final topic is genetic testing. Now, 2 studies published in the journal Health Affairs shed light on the role of genetic testing, and one was a survey of nearly 500 primary care providers. Now, this was a pretty striking results. 3/4 of these doctors felt that genetic tests that were capable of flagging a higher than average risk for specific diseases would be useful, and 70% said that they thought that genetic tests would improve clinical outcomes over the next 5 years. Yet only 1/3 of these doctors had ever ordered a genetic test or given results to a patient. Many of the docs cited cost and lack of insurance coverage as a problem. And the senior author of the paper said that lack of coverage could indeed widen healthcare disparities in access to genetic testing. His team is working on genetic testing of those with African ancestry that have a higher risk of end-stage renal disease. Certainly that's an interesting topic. Now, here are a few of my comments about this. That the majority of primary care docs, or doctors in general, think that flagging higher risk would be useful and that gene tests will deliver better outcomes speaks to our doctors' unbridled optimism about new things. Now, I'm a fan of gene risk scores for coronary artery disease prediction. I think they're pretty cool. But the truth is that these tests are clinically unproven. And further, we already have really good predictors of risk, which we can get with a scale, a tape measure put around somebody's abdomen, and a Timex to measure how fast they can walk. Whether genetic tests will incrementally improve on these basic measures of health is yet to be determined. On the matter of insurance coverage, I ask, why would insurance cover tests without proven benefit? Remember, we don't do tests just to get results of tests. We do tests to try and improve outcomes. And I can't help but say this, and it makes some of you mad, but one of the problems with high cost of care and inequities is that no one consuming or prescribing costly care has to make value judgments. I think it was Milton Friedman who said people are most careful about spending their own money. And no, of course not. I don't want people to have to forego emergency care. But gosh, if people knew how low value some of these things are, they'd be unlikely to spend their own money on them. And as for disparities in healthcare, it's these very practices, the flat of the curve, the low-value tests and procedures, the money wasters, that make this worse. When we waste money on low-value care, we hardly have enough to treat basic things, like, say, hypertension in young black males that were noted in the Black Barbershop study. Now, the second study in Health Affairs on genetic testing was also an eye-opener. I had no idea there were approximately 75,000 genetic tests on the market and about 10 new tests entering the market every day. And get this for numbers. The market for medical genetic testing is growing at a compound annual growth rate of 28%, and these researchers expected it to reach $7.7 billion by 2020. Now, don't get my comments on genetic testing wrong. I know there will likely be advances in gene testing that lead to improved health someday. But right now, it's way too early to be this optimistic. We need to be cautious, skeptical, and fund research. And this research needs to show and look at better outcomes before we spend precious resources on all of these tests. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.